Welcome to our 84th Blue Earth Virtual Seminar. Blue Earth Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Earth Ethiopia in partnership with Hill Venture Medical and Surgical Center. Blue Earth Ethiopia is a medical consultancy founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And Hill Venture is one of our partners. We just signed a huge contract partnership with them. So we're looking forward to working with them in the same regard in the future. I think Dr. Mugeta will introduce our host deeply. Dr. Mugeta, you can have the stage.
Venture, it's a newly established medical and surgical center that features around 14 patient rooms with 10 VIP beds equipped with modern medical technology, including sleep lab and multiple specialty services. This state-of-the-art healthcare facility promises to revolutionize the provision of medical services within our community. The comprehensive team includes specialists and subspecialists in various fields, allowing us to offer a broad spectrum of services such as colorectal surgery, endocrinology, ENT, gastroenterology, general surgery, hepatobiliary surgery, internal medicine, nephrology. So today, based on our collaboration with Blue Health, we have brought you a webinar on obstructive jaundice. This webinar will be presented by one of our subspecialists, Dr. Alaaeldin Awad. Dr. Alaaeldin is a distinguished Sudanese laparoscopic, hepatopancreatic, biliary, and organ transplantation surgeon, renowned for his experts and groundbreaking achievements in the field. His proficiency were recognized with awards from European Board of Hepatopancreatic Biliary Surgery in September 2019 and the European Board of Organ Transplantation in October 2018. Dr. Alaaeldin played a pivotal role in establishing the first specialized hepatobiliary surgery unit in Sudan, where he and his team have performed the first historic living donor liver transplantation surgery in Sudan in July 2022. Additionally, he successfully conducted a liver conjoint twin separation surgery in the same year, amongst many other wonderful accomplishments. With his exceptional experience and skill in laparoscopic, donor, and hepatobiliary surgery, Dr. Alaaeldin continues to push the boundaries of surgical innovation and patient care by joining Hill Venture's team of specialists. I will leave the floor to Dr. Alaaeldin.
Okay, thank you, Molly, and thank you so much for the partners in Blue Health Ethiopia. First of all, good evening for all the audience. With the respect of all of your levels, medical students, general practitioners, internal physicians, and surgeons. I'm Dr. Alaaeldin Awad Mohammed. I'm a HBB and organ transplant surgeon. A graduate Sudanese surgeon, graduated from the University of Khartoum 2007, and then started the journey of the general surgery, and then the renal transplant. Then I shifted to the liver transplant. Was trained in Shiraz Center for Organ Transplantation in Iran, and then for 4 years, and then I went to France for a couple of months in Paris, and then to South Korea, and then to Japan. So having getting multiple experience and different experience of how to do things, because the liver transplant and the hepatobiliary surgery is a wide spectrum with a different techniques. Then you have to get many of the West and the East to have a good techniques, and then come back home to serve our people and our country. We succeeded in making the liver transplant and establishing the first hepatobiliary unit in Ibn Sina Hospital in Khartoum. And we succeeded also to have like hundreds of hepatobiliary surgeries. And then we pushed the boundaries to have a first living donor liver transplant. We did 2 in 2022, but we were planning to have much more, but unfortunately what's our country passing through right now is miserable. We hope that we can get soon out of this crisis of the war, and we hope all the prosperity and the safety for our people in Sudan and in Ethiopia. And we're pleased to be in Ethiopia and to serve our brothers and sisters, the patients in Ethiopia, and enjoying the work in Helvetia Hospital, all the nice colleagues there. And I'm pleased and give me an honor and pleasure to have my first topic and presentation about obstructive jaundice with the Blue Health Ethiopia. So, as all we know, jaundice is a symptom, is not a disease. And actually, I think that also the physicians here in Ethiopia are facing this problem with the patients, because also in the Sudanese culture, people think that jaundice is a disease by itself, the lay person or the street person, as we said. So, you need a time to convince that the patient that jaundice and this yellowish discoloration is not a disease and it's a symptom for underlying disease. So that's why many times they go for traditional healers or traditional persons, and then they get some of herbs, some of many different traditional stuff. I think because I come to know, or we know that our culture are similar, I think that's the same to be here. So this is the first thing that we need to convince the patient. It's yellowish discoloration of the scleral mucous membrane, as all we know, and it's clinically predicted when the serum bilirubin more than 2.5 milligram per deciliter or 0.2 to 1 milligram per deciliter. And there's excess bile pigments in the plasma, definitely. So as we know all, it's either a prehepatic, hepatic, or post-hepatic jaundice. For the prehepatic jaundice is mainly unconjugated bilirubinemia that's arise from many underlying disease like congenital hemoglobinopathies or hemolysis, multiple transfusions, sepsis, and burns. And this especially we can see in the children, especially with sickle cell disease. It's most commonly seen in Sudan, in the east of Sudan. I think also here in Ethiopia, in some parts, there is a large number of sicklers. Impaired hepatocyte uptake, the Gilbert disease, or a drug-induced. Also, because of reduced conjugation, as in neonatal jaundice and Crigler-Najjar syndrome. And by the way, this one of the Crigler-Najjar syndrome, one of the causes of the transplant in pediatrics. The impaired transport and excretion, and this will lead to conjugated hyperbilirubinemia, like in hepatitis, cirrhosis, Dubin-Johnson syndrome, and Rotor syndrome. And I think hepatitis, especially in patients who had an active hepatitis, an acute hepatitis, it can give like a similar picture to an obstructive jaundice. And you have in the LFTs very high alkaline phosphatase. And this usually is mistaken somehow between us in surgery and the hepatologist, and it's usually caused by an intrahepatic cholestasis. When in hepatitis, and especially acute hepatitis, you find that there is intrahepatic obstruction because of the swelling of the hepatocytes. So it's give a picture of obstructive jaundice. The other, or the surgical jaundice, the third type, is the biliary obstruction, the post-hepatic jaundice, that's conjugated hyperbilirubinemia. The results or the underlying cause could be a choledocholitis, benign strictures, chronic pancreatitis, sclerosing cholangitis, PSC, perambulary cancers, cholangiocarcinomas, distal cholangiocarcinomas, or perihilar cholangiocarcinomas, as we are going to see in the presentation. As all we know from physiology, that 95% of the bilirubin is unconjugated because it's albumin binding. The lesions that associate with the biliary obstruction, that's the post-hepatic causes of jaundice, is either complete or incomplete. As you know, that type 1 complete obstruction usually is caused by tumors, like tumors in the head of the pancreas, which is the most common. Common bile duct ligations, and this usually happens as an iatrogenic causes, this post-surgery, that could be ligature or as biliary injury, with all types of the biliary injury or classifications. Cholangiocarcinomas, and pancreatic liver tumors, primary or secondary, which is in the bottom of the differential diagnosis because it's a rare or like a minimal percentage cause of the complete obstruction. Type 2 intermittent obstruction, that's choledocholitis in some cases, and in some cases also the choledocholitis can cause a complete obstruction. Periambulary tumors, and especially this for the medical students, or as we know in the history taking, the patient will say that the jaundice appear and then disappear, and it's on and off jaundice, and we all know it's because of the sloughing of the tumor, because it overgrow its blood supply. Duodenal diverticulum, choledochal cyst, polycystic liver disease sometimes can cause this systemic obstruction, biliary parasites, and hemophilias. And especially these hemophilias can be seen in the vascular tumors of the liver sometimes. It can cause these hemophilias, or sometimes after interventions, especially if there is intervention radiologists having doing some procedures with the liver. And sometimes also we see after liver transplant, when we do the transplant and the patient gets some bleeding inside the bile ducts, it can get some hemophilias and obstructing the lumen. Type 3, chronic incomplete obstruction, like strictures of the common bile ducts, traumatic or iatrogenic. As we said before, that the iatrogenic strictures can cause a complete or incomplete obstruction, but many of the times it causes incomplete obstruction. Sclerosing cholangitis, post-radiotherapy, stenosis of the biliary enteric anastomosis, and this, by the way, we saw much after the surgeries. Sometimes it happened after liver transplant, but most of the cause of the stenosis is due to duct anastomosis in transplant and not to a biliary enteric anastomosis. But although biliary enteric anastomosis can cause some stenosis. Chronic pancreatitis, cystic fibrosis, and sphincter of Oddi stenosis. There is a type of segmental obstruction, traumatic, especially we're going to see one of the imaging that shows how is the traumatic obstruction can cause segmental obstruction. Intrahepatic stones, especially if the stones are forming inside the liver. Sclerosing cholangitis, this is the most famous cause of segmental obstruction. Actually, these causes are not common in our races, like in the Ethiopians or the Sudanese. It's most common in the Caucasian race. That's why we saw this when we traveled, and we had especially in Iran or in Asia, because of the Caucasian race. So you have these autoimmune disease like PSC, autoimmune hepatitis, or combined PSC. Cholangiocarcinomas can cause segmental obstruction, especially if there are multiple tumors. We are all know of the obstructive jaundice, the most important is knowing the biliary anatomy. It's a quite important thing. We have to speak about the pressure of the biliary system, and this happens or well known with the surgeons, especially after doing cholecystectomy and common bile duct exploration. That's why we are going to put the T-tube, because the pressure in the portal in the bile duct sometimes can come high, and it will lead to the backflow. So that is important to have a T-tube. But in some cases or some surgeons, the technique differs and they don't put a T-tube. But usually, or in the teaching, especially for the undergrad, you say that it's a must to have a T-tube. But when you come more like advanced surgery, sometimes you have these techniques in different schools of surgery. In obstruction, there is a reflux of the bilirubin. It alters the structure of the biliary system and lead to this dilatation of the intrahepatic and extrahepatic biliary system, which is a cornerstone finding in the ultrasound imaging of the liver and of the abdomen, and this by which you can distinguish between the jaundice that is post-hepatic jaundice, or either it is a hepatic or a pre-hepatic jaundice. And always in our teaching for undergraduate, we teach that the intrahepatic and extrahepatic biliary dilatation is the cornerstone feature of the post-hepatic jaundice or obstructive jaundice. The altered bile production, that's the bile production, will become less lithogenic, that's less forming stones, especially with alter of the cholesterol and the phospholipid. And this happens usually with the stent closure. Whenever you pass through a stent closure in ERCP and stent placement, this will alter the bile formation and become more stone forming. This schematic representation showed the biliary anatomy. It's quite nice schematic representation. We always it's very famous for the hepatobiliary surgeons to have this nice this nice picture in their presentations. So as we see in A, this is a normal thing. That's a gallbladder with a cystic duct. This is draining into the common bile duct. Here in B that we see that the cystic duct is short and it's open in the confluence of the right and the left hepatic duct. In C, we see that the cystic duct draining in the common bile duct, but there is a right hepatic duct draining. There is two right hepatic ducts draining in the common bile duct and right hepatic duct draining in convergence with the left hepatic duct. And usually this one is the right posterior hepatic duct, the one that's draining in the CBD. In D, we see that the cystic duct is draining directly in the right hepatic duct. And in E, we saw that there is accessory duct that's from the gallbladder draining directly into the liver bed. And in E, this is one of the causes that sometimes we have problems in lap cholecystectomy, that we have a drainage of a bile from the liver bed. If you didn't see this or you didn't get notice that this duct is there, usually it's not a big size, but the one that causes problem, especially in liver transplant and in the donor, when we get the liver from, is the D, B, and C. And especially the C one, because you have to know the biliary anatomy well for the liver that you are taking from the donor in order to have your plan in suturing it to the bile duct in the recipient. So this showed also this picture that showed an MRCP. You can easily see in the arrows that showed the gallbladder, and there is a long tortuous cystic duct, and there is a right posterior duct draining into the cystic duct itself, the one with the long arrow. You can see it easily. On the left side, you can see type 1, type 2, type 3, and type 3A and 3B of this biliary anatomy. And this especially for the right hepatic or right posterior hepatic duct drainage. You can see in type 1, the right posterior duct is draining into the right hepatic duct posteriorly. In type 2, the right posterior hepatic duct drains into the convolvulus of the right and left. In type 3A, and this, by the way, this is the difficult, this is a nightmare for a transplant surgeon. And it can cancel a donor of being a donor. That is, the right posterior hepatic duct is draining into the left hepatic duct. And then in type 3B, you can see that the right posterior hepatic duct draining into the common hepatic duct. So there is a macro and microvascular perfusion of the liver. It's quite important that the intravitreal fluorescence microscopy showed that there is significant increase in the number of the non-perfused sinusoids after 3 days of extrahepatic obstruction. This is one of the pathophysiology effects of obstructive jaundice on the hepatocytes, that it can derange the function of the hepatocyte by abnormal perfusion of the hepatocytes. So the perfused sinusoids, you have 35% decrease in the mean diameter and 25% decrease in the flow velocity of the blood vessels to the hepatocytes, and by which you can get some derangements of the liver function due to the biliary obstruction. This representation or this scheme showed that how the obstructive jaundice can affect the renal system or renal impairment. That's by having decreasing the Kupffer cell clearance. It can decrease the clearance of the cardiotoxins. It can affect the cardiovascular system, and through affecting the cardiovascular system, it can affect the erythrocytic peptides, and hypolispadias leads to decrease the left ventricular function and reduces the plasma volume, reduce peripheral resistance, and that's why in some of the obstructive jaundice patients we can have a bradycardia and also a low blood pressure, and this can affect the renal system. Or it can affect the renal system directly by endotoxemia that arising from due to obstructive jaundice, and sometimes due to the sepsis and bacteremia that happens, and the cholangitis that happens, it can lead to general sepsis, and the general sepsis can affect the renal system. By the way, for all the undergraduates and the medical students, that's cholangitis or septic cholangitis is a medical emergency, and usually the patients better to be treated in the ICU because they have a high mortality, about 80% mortality. So it's a very serious condition to have a patient with cholangitis due to biliary obstruction, and the urgency is to drain the patient as soon as possible. And we can see forwards in the presentation some types of drainage. The other affection of the obstructive jaundice is the coagulation system, the immune system, and the wound healing. We as surgeons are we are very much interested in the wound healing in many of the studies, especially the Grande and colleagues studies. It's a very famous study for showing the effect of the obstructive jaundice on the healing. That there is an enzyme called the skin propyl hydroxylase activity will be reduced in obstructive jaundice patients, and this enzyme are very famous of producing what's called the propyl hydroxylase protein, and this propyl hydroxylase protein, or what's called proline hydroxylase, is most responsible for the stable collagen. So that's in jaundice patient, you have only 11% of the skin propyl hydroxylase activity, and this will definitely lead to the reduction of the proline hydroxylase, and definitely will lead to reduction of the stable collagen, and it will delay the wound healing. So when you speak about jaundice as a symptom, then you need to know the symptoms of the cause of the jaundice, and this is the quite important thing. When you handle an obstructive jaundice patient, the art of history taking is quite important, that you need to know the symptoms of the cause, the specific symptoms of the cause, the general symptoms of the cause, and the symptoms of the complications. And the most important is the renal system complications symptoms and the hematological system complications. So for any general practitioners or like undergraduate medical students, these important things should be shown in your history taking. And for us, when we were examining the medical students, we are very much pleased if these all are well shown in the history, and this will reflected on the mark of the student, definitely. So many physiological derailments induced by obstructive jaundice, and it takes time to recover or to reverse. That's the hepatic mitochondria was not returned to normal even 7 weeks after the relief of the obstruction, and this same prolonged effects of obstructive jaundice has been noted with the lymphocyte, polymorphonuclear cells, and Kupffer cells functions, as we saw in that table or schematic presentation that we have. So when we speak about the etiology of the obstructive jaundice, the surgical etiologies, either bile duct stones, the main surgical etiologies, or pancreatic ductal adenocarcinoma, which is the most common carcinoma, the PDAC, and less commonly the ambulatory tumors, periambulatory tumors, PSC, cholangiocarcinomas with the different types, either perihilar cholangiocarcinomas or distal cholangiocarcinomas. The intrahepatic cholangiocarcinomas are rarely to cause obstructive jaundice, and usually it doesn't cause obstructive jaundice because it presents as a liver mass, not as obstructive jaundice. Pancreatitis, especially the chronic pancreatitis, can present with obstructive jaundice. So when you approach to jaundice patient, as we saw in the previous slides, that's the careful history is quite important. That the onset of the jaundice, the duration of the jaundice, is it painless jaundice or painful jaundice? That is to say, i.e. is associated with abdominal pain or no. The cause of jaundice, was it progressive jaundice, intermittent jaundice, or remittent jaundice? What's the associated symptoms that we saw in the previous slides? The symptoms of the cause and the symptoms of the general symptoms of the cause and the specific symptoms of the cause, and then the symptoms of the complications, either the renal system or the hematological system, the bleeding tendencies, etc. And the systems of other systems that's related, like, for example, PDAC with lung metastasis or with liver metastasis, with metastasis elsewhere. So wherever there is, the history is going with a malignancy, then you have to look for the symptoms of the distant metastasis. In the past medical history, especially if there is a biliary surgery, and this is what shows the art of history taking. Whenever we teach medical students, we emphasize on the history of the art of history taking, because wherever you reach the specialty in medicine, you are a consultant, you are a subspecialist, you are not a good history taking, then you will lose the patient and you will lose the diagnosis. So especially if a patient have a biliary surgery like a lap cholecystectomy or an open cholecystectomy, you have to dig deep in that. For example, to know, was it a lap cholecystectomy? Was it is converted to an open cholecystectomy? Was you discharged after the surgery to the ward with a drain? Was that drain draining blood or a draining green material? So that's all that stuff is quite important when you was discharged from the hospital, etc., etc., etc. So these are quite important things to take in the history. And it showed that was this surgery complicated, was this surgery difficult, and that shows a high liability of having a biliary injury. And the clinical examination, the most important thing when you examine a patient is to plan for your examination, what you want to see, depending on your history, and what you are expecting to see, especially for a patient with, and I think this goes well with the Courvoisier law. That's said in the jaundice patient, the palpable gallbladder, the cause is unlikely to be a stone. This is a law that's well known for all people in the surgical arena, and we are very much in medical examination asking the students about. So you expect the findings in the examination depending on what you get in the history. You examine for pallor, for jaundice, for the lymph nodes, and it's quite important, where is these lymph nodes? And by finding these lymph nodes, you can, just from the examination and the history, you label this patient as advanced, and this patient is not for surgery. For example, you have seen the Virchow's lymph nodes, that's the cervical lymph nodes, or you see cystabiosic nodules in the umbilicus. So definitely this patient is an advanced disease, an advanced tumor, a pancreatic tumor or ambulatory tumor or severe. So just from the history and examination, you label this patient as advanced, and your CT scan is just to affirm your diagnosis. Congested liver is quite important to notice, palpable gallbladder, Courvoisier law, and this is the important thing, that to say that we don't plan to plan, and this is important in surgery, especially for us surgeon. You have to plan and plan and plan. For the investigations differ in a laboratory investigations, imaging, and non-invasive and invasive imaging, and then we'll go for the surgery. As we all know, for the investigation, the CBC, the complete blood count, you look for the pallor, you look for the hemolysis, especially if the patient is a child. You might going up to request a blood film, for example, a renal function test for the complication. The liver function test is quite important to know which enzymes is elevated, to see is it direct bilirubin or conjugated or unconjugated. The urine analysis to see the urobilinogen and the bilirubin, the coagulation profile, PT and PTT-INR, and the tumor markers. It's quite important to have, especially if you are thinking about malignancy, to have a tumor markers. These tumor markers is not only diagnostic, but it is for a follow-up. For example, all patient that's had a Whipple surgery for pancreatic ductal adenocarcinoma should be followed by tumor markers, alpha-fetoproteins. Patient who have a cholangiocarcinoma, we are following by tumor marker CA19-9 after surgery, looking for metastases and so on, and the carcinoma membrane antigen also. So the imaging, the hepatobiliary specialty or the hepatobiliary surgery depends on imaging so much, and we like to have these MDT meetings, and you couldn't have a good hepatobiliary unit without an MDT meeting. In this MDT meeting, we have the hepatologist, the radiologist, even sometimes the anesthetist is there to decide on the endoscopist, if the endoscopist is not the hepatologist, for example, to decide about the patients. So the primary investigations or the imaging, is the ultrasound. In this ultrasound, we saw the biliary system dilatation, and these two schemes of the ultrasound showed exactly, each of them explained the others, the right hepatic duct, the left hepatic duct, and the common bile duct. Here in ultrasound, these arrows shows the stones inside the gallbladder, and here you can see the acoustic shadow of the stone in the right side. This acoustic shadow, this shadow that's appearing below the stone, below the white thing, is the acoustic shadow of the stone. Here also you can see a hyperechoic gallstone inside the gallbladder, and it shows the gallbladder wall, and the posterior shadowing is quite obvious. The MRCP or the MRI imaging, when to request, I put the MRCP before the CT scan because important question is when to request an MRI or MRCP. Usually in hepatobiliary surgery, the MRCP is a problem-solving modality image. You don't request the MRI or the MRCP unless there is a problem with the CT scan and you want to solve this problem. You don't reach a diagnosis, or you are in a query of two diagnoses. Then you request the MRCP or the MRI. The other thing that is the MRCP, especially in certain types of cases, that the biliary injury cases, is quite important because it gives us a biliary mapping. You see the map of the biliary system as showed here exactly. This showed the CBD, the cystic duct, right hepatic duct, left hepatic duct. You can even follow up to the intrahepatic biliary system, the small ducts for the segments of the liver. That's B3, B2, B4. And you can see the right anterior duct and the right posterior duct on the right side. This absolutely, when in the field of the liver transplant, is quite important to know, and especially for the pediatric transplant, because we decide which segment that we're going to take and which duct that you're going to anastomose and so on. When you do also the hepatic surgery for hepatectomy, right or left hepatectomy, you need to have these ideas. This also another MRCP. This MRCP here, and this is a live, this is a real image that we took from our patients that we faced. You can see the duct, the biliary, the common hepatic duct contain filling defects, and these are stones in the common bile duct. I will just reduce the image to show you. Yeah, this one. This is stones, and this is stones in the CBD here. Okay. Yeah, we come. And this is the cornerstone of the biliary adhesion, the CT scan. We love the CT scan, and we love to discuss the CT scan with the radiologist. And sometimes we argue with the radiologist the beauty of the MDT. We think that patient can be good without interpreting the CT scan by himself. So these CT scans show the tumor in the pancreas, in both of them. I'm going to reduce again to show you. This is a tumor. In the cystic tumor, is appearing in the different cysts here. This the whole pancreas is enlarged. Most commonly, these tumors or this pancreatic enlargement is a form of an neuroendocrine tumors that's multiple in the pancreas. This one is a cystic endoplasm pancreatic tumors. You can see here the quite important thing in the CT scan to see the effect of the tumor. You can see here there is no dilatation of the pancreatic duct, and this is quite important to know in pancreatic surgery because it gives you a clue to that how is the anastomosis going to be with the pancreatic jejunostome. So going back again, another CT scan. This arrow showed the CT scan on the left side with the arrow showed the metastasis in the liver, and the right side CT scan showed a dilatation of the pancreatic duct. Here you can see this pancreatic duct is dilated, and by a tumor, a teeny tumor, not like the previous one tumor big. So this dilatation, this usually a neuropancreatic tumor here obstructing the biliary system. So this is the beauty of the CT scan. You can read the CT scan, you can know the diagnosis, you can plan your surgery, you can know the difficulties of the surgery. If the pancreatic duct is big, large, dilated, then it is easy to anastomose. If it's small, then it's difficult to anastomose. So the information needed from the CT scan, that not only what's the tumor obstructing, we need to know the pancreatic duct. As in the left side, you can see the PD is the pancreatic duct. You see the mass, you see the CBD dilated, you see if there is metastasis or no, if there is ascites or no. And the most important thing to know the local advancement of the tumor, especially in hepatobiliary surgery and in pancreatic ductal adenocarcinomas or distal cholangiocarcinomas. We should know the vascular involvement. That's the portal vein and the superior mesenteric artery. The superior mesenteric artery is the one that we can see here. I will go also to shrink it again to show you. This is the SMA. This is the SMA here. So these arteries, if they are involved with the tumor, especially the pancreatic tumor, so it's difficult to this label the patient as inoperable. And if there is no metastasis, patient can have a sessions of new adjuvant treatment and then to come again for reevaluation for surgery. If they are away from the artery, then we can go for the surgery. The portal vein involved, this is the portal vein. This is the portal vein. Okay. So this portal vein, this is the splenic vein. This is the portal vein. A portal vein involvement in the past, it was a contraindication. But afterwards, with the advancement of the technique, it's no longer a contraindication for a Whipple surgery or removing a pancreatic ductal adenocarcinoma. We can remove part of the portal vein and reconstruct the portal vein. We can graft the portal vein. We can replace the portal vein with another graft, synthetic graft. All this can be done for a tumor, pancreatic tumor involving the portal vein. Even though for the superior mesenteric artery, in some centers of the world, they do vascular resection, especially in Germany. One center called the Heidelberg Hospital, it has the highest number of vascular resections, superior mesenteric arteries, and replacement for them, for the pancreatic cancer. So the ERCP, as all we know, is a diagnostic and therapeutic. That is, the role of the diagnosis is becoming less because it's an invasive procedure. So it's mainly therapeutic. And this is what we said in the beginning. If you have a patient with a cholangitis, so the ERCP and the drainage of the biliary system, it's a must and it's an emergency, and you should do it ASAP, as soon as possible, because it's a killing disease. Here you can see that the biliary system is dilated, common bile duct. You can see the right hepatic duct, the left hepatic duct, and the right hepatic duct, even going to the segmental branches. This is a leakage from the cystic duct here, and especially this is after surgery, and you can see the drain after the surgery. For the excessive drainage, you have this. You detect so the simple story of this patient, you can detect that the patient, after a difficult he gets out from the surgery with a drain, and the drain continue to drain bile. So we go with an ERCP. You see this leakage. You put a stent here, and this was in the first slides about the pressure of the biliary system. This pressure lead to this leak. So when you put a stent or you do sphincterotomy, then you will release the pressure. All the bile goes from here, and it will never leak from this stump of the cystic duct. Here you can see this is a filling defect. Most likely this is stones here obstructing. So you can remove it by sphincterotomy or by Dormer basket. And the most important thing that you should, even the endoscopist, to know that if there is a possibility of failure of the ERCP, for the surgeon to be at hand. In some countries, the surgeons do the ERCP and the physicians. In other countries, only the physician doing the RCP. In others, only the surgeon. So it doesn't make a big difference if there is an MDT, and that's the importance of the MDT. This is one of the beautiful things in the hepatobiliary. That is the biliary drainage, the PTBD, percutaneous transhepatic biliary drainage. It have a revolutions in it starts with the PTC, that's percutaneous transhepatic cholangiography. That's an imaging technique. Then it goes to PTC and drain, percutaneous transhepatic cholangiography and inserted drain. And nowadays is a PTBD, percutaneous transhepatic biliary drainage. What we use to drain the biliary system. If the ERCP, the modality we saw previously, failed, then we go for the PTBD. We go immediately for the PTBD if the tumors are obstructing higher up. That's to say here in the perihepatic cholangiocarcinoma. If the patient having a perihepatic cholangiocarcinoma, usually the ERCP will fail. That's why we go immediately for a PTBD. It can be done through here like this from the right, or it can be done from the left. Definitely from the right need more expert. That's why more expert intervention radiology goes from the right. From the left is less, it needs less experience, but in general, it's an intervention that needs an expert guy. You can see this here in the fluoroscopy is going through this Shiba needle, and then they stent here. You can see the dilated system. So going back, the beauty of the intervention, in these two, you can see the drain. This one is an internal external drain. This drain is going inside until it reaching the duodenum. So this is an internal external drain. There is two types of drain, either external drain, the only bile duct will be drained outside in a urine bag, or there is an internal external drain that you put and you get inside up to the duodenum, and then you close this and the bile draining inside. So this is definitely this is a stent. You can imagine this is a stent in a portal vein, by the way. So this is the beauty of the intervention radiology. The intervention radiology will help a lot in hepatobiliary. So this is one of the nasty things that one can have in the world, and you can see this image shows this like 1, 2, 3, 4, 5, 6, 7, more 11, maybe 20 clips. This is a complication of a laparoscopic cholecystectomy. Unusual story that's happened, a bleeding happened, and then you're going to clip, and you end with this to stop the bleeding. And surprisingly, if you just keep calm and you stand on the patient, the cystic artery will stop bleeding by itself. So that's why in the training and the learning curve of teaching laparoscopy and having a unit with the residents and with an intern, people get this with experience. So this one showing this nasty thing, also multiple clips. You can see the results of this clipping. Totally obstructed left-right hepatic duct. You can see here, and this will give a hard time for the surgeon who are doing the biliary reconstruction. So PTBD here, this is a percutaneous cholecystostomy. It's not like the PTBD that we saw before, because this is the easiest thing to do here. You go with the needle. We go with the needle into the gallbladder, and I think many of the people, or like if a surgeons here attending, this is done sometimes open. By open surgery, or most of the time we do by open surgery if there is an empyema of the gallbladder. If the gallbladder due to obstruction or acute cholecystitis, it become an abscess and go inside. We put a Foley catheter and we go out. We don't contemplate cholecystectomy because it will be difficult and there is high incidence of injury. But it can be done in this, not with an open surgery. Just to put the drain here, you drain the pus, and then you come after a while, you do a cholecystectomy. The patient can be discharged even after getting the pus out, and then come for an elective cholecystectomy. So the management of obstructive jaundice in hospital admission, definitely IV fluids, fluid chart, input output chart, start with antibiotics. Right nowadays, the old teaching that you have to start antibiotics as a prophylaxis, but nowadays some schools of surgery is going for starting antibiotic only if there is an indication and there is a fever or high total white cell counts or high CRP, or an indication for that. So there's different schools of doing that. The diuretics or the mannitol, people in the past use furosemide, not right now mannitol. Some of the schools says if there is a good output and good urine output, so there is no need, just give a good hydration, a good fluid input. The anticoagulant you can use as prophylactic, especially if there is a derailment of the coagulation, then you can use analgesics, especially to kill the pains. So in the treatment also you have to plan, again planning. So the goal of your treatment, you treat the obstruction, especially this will become a priority if there is a complication or a cholangitis, then the obstruction will come to the top priority, and then to treat the cause. You prevent and treat complications, you prevent recurrence, and this is quite important, especially in surgery. You speak about recurrence, the type of surgery you are going to do, the lymph node resection you are going to do. The good surgeon is the one who has less recurrence, because the recurrence depends on the surgical techniques, not like the metastasis. The metastasis is the biology of the tumor, but the recurrence, the surgical technique. So it depends, all this depends on what is the cause, is benign or a malignant cause. So the first question is, what's the cause? The important question, is it early or late, especially when speaking about tumors? Is it early tumor or late tumors? Because you need to know that you are aiming to cure or to palliate. even if it's a low tumor, is it a local advanced tumor or a metastatic tumor? As we saw in the CT scans, the information that you get, if it's the involvement of the portal vein, if there is an involvement of the spermogenic artery, if you are going to plan a new adjuvant treatment, and then you re-evaluate the patient. So this is important in the local advanced tumor. So the early, you are aimed for curate, late, you are aimed to palliate, and the important question to ask when you are aiming to palliate, what you are going to palliate. Are you going to palliate pain? Is the patient main complaint is pain? Are you going to palliate jaundice? So difference. It differs the palliation on what you are palliating. So when speaking about CBD stones, the RCP, as we saw, is a curative if you can extract by sphincterotomy, by Dormian basket. But it's important to expect failures. When to expect failures? If there is abnormal anatomy, if the stones is big, usually more than 3 centimeters, then you have to have a surgical service beside you. And this is what I said about the beauty of the MDT. CBD exploration, you can do you can treat the CBD stone without the RCP. You go for CBD exploration. In the past, where is an open surgery, then the RCP took place and it became in favor. Nowadays, when the CBD exploration is done laparoscopically, so the ERCP is coming in a challenge with the laparoscopic cholecystectomy and CBD exploration. Although the challenge is in favor of the RCP, definitely, because there is no general anesthesia. So whenever there is no general anesthesia, it's the best for the patient to have. Yes, it can be done with an expert hand, the cholecystectomy and CBD exploration laparoscopic, but at the end of the day, there is a general anesthesia and there is a risk of general anesthesia. So if it's better to go with the RCP, you go with the RCP. But also here, the schools differs. So the stones that go better to cause obstructive jaundice is rarely, as we know, what's called the Mersey syndrome. So as I said, it can be done open on laparoscopic. So benign strictures usually is iatrogenic due to CBD injuries, due to difficult cholecystectomies, either open or laparoscopic. In these days, it become with the laparoscopic cholecystectomy. As I said before, when I speak about the MRCP, is the cornerstone imaging, a mapping of the biliary system. You need to know where is the stricture, stricture, is the injury only in the CBD, in the right, the left hepatic, and all that's classification. It had a certain classification that is more detailed with, we'll speak when we like present to the hepatobiliary surgeons, or that's the biliaries have difficult other classifications. So the difficult surgeons need definitely and more expert surgeons. So intra-op decision to repair or to reconstruct the biliary enteric anastomosis. And this by the way, difficult decision that if you find if the injury happened inside and you detect the injury, it's better to repair it immediately. But the capability of the surgeon to repair it difficult. If the surgery is done by a general surgeon, then definitely you will not have the capabilities of the knowledge of repairing, and it's need an expert surgeon. In the first world countries, I remember that we attend a surgery that there was an injury, and the patient was shifted directly to a helicopter from the hospital to other hospital where there is a hepatobiliary surgeon, and from the helicopter directly to the OR, and he had his reconstruction needed. But that's the facilities differs definitely. So the PDAC, the pachyductal adenocarcinoma, is 52% of the patient who have a distant disease. It's the most common. But in our setting, because of the late diagnosis, that's why what I said in the beginning, the art of history taking, you have to put in mind that obstructive jaundice in elderly patient, please don't think about stones. And this is especially for the medical students in this session. Elderly patient having obstructive jaundice, think about cancer early on. Think about it, do CT scan. It's better to rule out the cancer rather than to say, no, it's a stone, and then the patient goes and then stay in home for 2 days, for 2 months or so, and then come back with a metastatic disease. Elderly patient having abdominal pain, just even before he start to have jaundice, you analyze well, you take a good history, good examination, and it is justified to have an imaging like a CT scan. Because later on, he will go to the home, stay 3 months, then he will come with jaundice. Sometimes it's very advanced and he have a metastasis. So put in mind, plan things, have a good history, put in mind the sinister diagnosis first, and rule them out is better than to say that the patient is cannot afford, for example, a CT scan and just this ultrasound, and he can go home and then he come after 3 months with a distant disease and metastatic. So labeling the patient either is resectable or irresectable for the local advanced tumors. So serial skills and competency make difference definitely, and the overall health of the patient you have to search for, and you assess the patient well because they are usually elderly patients. They're having other diseases, they're having other comorbidities, diabetic, hypertension, they can have heart problems. So that's why we send usually this patient to a cardiologist to have a cardiac assessment. In some of the cases in our setting and in our experience, patient discovered to have a coronary disease and they go for angiography and stenting, and then afterward they come for a pupil surgery. We have like 5 or 6 patients as such. So that's why speaking about MDT is quite important. So distal cholangiocarcinoma, periambulary cholangiocarcinoma, ambulatory tumors, they are the same as the PDAC in their treatment, not definitely in their fate or their prognosis, but in their treatment, they are all treated with Whipple surgery, either a classical Whipple or pylorus preserving pancreatic duodenectomy. They have different 5-year survivals. The lymph node dissection and the clearance is different. Surgical techniques are different, definitely. And the postoperative course depends on the intraoperative procedure. While there's a chylic, there is a fistula, postoperative pancreatic fistula, there's delayed gastric emptying, and so. Perihilar cholangiocarcinoma, that the one I spoke about in one of the drawing, usually at the hilum of the liver. Usually here we treat with CBD, excision, and hepatectomy. It's not like a Whipple surgery. Yes, the distal cholangiocarcinoma we treat with a Whipple surgery, but the perihilar we treat with CBD, excision, and hepatectomy, whether it's a right or a left hepatectomy. It's advanced procedure, need a good pre-op evaluation and evaluation of the patient overall health. Liver health is quite important because you are going to do a hepatectomy. So whether it's a cirrhotic liver or a healthy liver, and here we speak about a future liver remnant. This FLR is the how much we are going a volume for the patient of his liver. Usually in a cirrhotic liver, you have of the liver. In a healthy liver, you can take more and you can live up to 40 or and there is a technique to increase the volume of the future liver remnant. And these techniques we are going to speak more if we have a session with the hepatobiliary surgeon or with the surgeons. So in the conclusion, ladies and gentlemen, is the careful history and examination, planning is quite important to safe handling a patient with obstructive jaundice. You choose your investigation according to your art of history telling and what you reach in your differential diagnosis. You expect the findings. It's important what you are treating, early or late disease, what you are palliating with an advanced disease. The quite important difference between surgeons is the question of when to operate and when not to operate. There's a big wisdom in surgery that saying a good surgeons know how to operate. A better surgeon know when to operate. The best surgeon knows when not to operate. You expect complication beforehand. If you have a good planning, plan. Thank you all. Please all pray for Sudan, for our country and our people. God bless us all in Ethiopia and in Sudan, and wish you all a good night. Thank you.
All right. Thank you so much, Doctor, for the amazing presentation. I hope everybody listened to it without any interruption. And I'm seeing a lot of thanks in the chat box. And on behalf of Blue Health and our participants, we want to thank you for presenting such an amazing session. I think if you have time,
we can have a couple of questions. I'm very pleased to have them.
Okay, so participants, if you have any questions regarding the topic, please write it in the chat box. And Dr. Alaaeldin.
Yeah, can you give me, I think if you can give me permission to open the chat box. Yeah.
Okay. Can you reach out or should I, Doctor? the chat box.
They can ask because I don't see question in the chat right now. Thank you all for all the thanks.
Yeah.
I really appreciate. Thank you for we need your blessings for our country, our nation.
Yes.
Thank you. May God save us all in Ethiopia, brothers and sisters in Sudan. Thank you all for these nice feelings. Thank you. Thank you.
Yeah. You can see it was an impactful session, so there is a lot of
As a
thanks. Yeah.
GP, what is the role I can play for a patient with obstructive jaundice? Biruk, if I can pronounce it well, yes, it's a much. First of all, the first thing is the good history and examination and like predicting the cause. And in elderly patient, if a patient came to you with abdominal pain, don't just only predict that it is like an H. pylori or so. We have this much in Sudan. The patient diagnosed with H. pylori and then he go after 3 months, he come with an advanced tumor, either liver tumors, pancreatic tumors, especially for the pancreas because the pancreas is a retroperitoneal organ. So in order for it to be big and have symptoms, then you are in trouble at that time. So usually a good expectation, good history taking, and then you can predict that this patient might have an intra-abdominal catastrophe or intra-abdominal tumor. Just by requesting CT scan, you can get the tumor as early as possible, and then you make the life of the surgeons or the specialist easy, that he will deal with a small tumor. You make definitely the future of the patient different because he will have a curative surgery, not a palliative surgery. So you can right now know how much impact and difference you can do to the patient. So as a GP, you are a quite important person in this cycle of treatment because you will differ the life of the surgeon. You can give him a hard time. You will differ definitely the life of the patient. You can give him a good life and a good 5. Detect the tumor early and it was treated as a curative, and he can have a bad 5-year survival or even a pick it early. In obstructive jaundice patient, you have to know if the patient is having ascending cholangitis, so it's an emergency. You have to shift him fastly to the hospital, start him on antibiotics. If you are in a rural area or away area from, start him on antibiotics. At least you save the times for the sepsis, because when you speak about sepsis is a matter of time. We have a golden hour to save the patient. So your intervention here is quite important, and it makes a big difference. Then shifting him to a hospital center where there is a specialist, they can treat him, and they think about drainage as a priority. Then totally the life of the patient and the outcome will differ. So this is some of the difference that you can do as a GP. Other questions? Okay, yeah. Then could you brief us ultrasound about Charcot triad and renal pentad? Yeah, the ultrasound, the Charcot triad and the renal pentad, like it's a triad of jaundice, fever, abdominal pain, and this, like the ultrasound here have nothing to with the Charcot triads or the pentad. It's mainly about here we speak about the symptoms and signs, but in the ultrasound we speak about the findings of dilated intrahepatic, extrahepatic biliary system. We speak about acoustic shadow for stones. We speak about like a metastasis in the liver due to a tumor that you will detect by CT scan on the MRI. So it differs. So you cannot say that there is an ultrasound finding or this and this, no. But there is an ultrasound finding of an obstructive jaundice, and if there is a cholangitis, and it's on the counter side or the other side, there is the Charcot triad or the round pentad. So how do we differentiate icteric sclera caused by obstructive jaundice and other causes? Definitely is by the history. The icteric sclera due to obstructive jaundice, there is itching, is usually the jaundice here. If it is a tumor, then it's a painless jaundice. If it's a stone, it's a painful jaundice. This totally differs from other causes, the pre-hepatic and the hepatic causes. And definitely there is the symptoms of the underlying causes. For example, congenital hemoglobinopathies or the hemolysis. The patient will have the features of anemia, weakness, exercise intolerance, fatigability, etc., etc. So these other things you can differentiate in the history, and especially in the examination. For example, hemoglobinopathies, hemolysis, you will find hepatosplenomegaly, other things. Here you can have in the obstructive jaundice due to tumors, you can have this palpable gallbladder, you can have this lymph nodes that we saw or we speak about. So other questions? Yeah. Okay. As public health officer, what can I do for my patients? Yeah, I think when I spoke about the GP is somehow to do with this question, isn't it? I think the early referral is quite important. The misinformations that we get from, I spoke in the beginning of the presentation, the misinformation of the jaundice itself as a disease. As a public health officer, it's a big responsibility to change the culture, the health culture of the community. That the jaundice is not a disease, is a symptom, and the jaundice is not treated by herbal medications. Then you have to present to the health service, to the health center, and then you might go to the hospital or even a tertiary hospital. So that's the quite important responsibility of the health sector. By the way, in health and in medicine, the bigger responsibility is not on the consultant or the specialist in the hospital, in the fancy hospital or in the tertiary hospital. No, it is in the public health officers and in the GPs and in the health centers. That's why in our systems, in like our countries, Sudan, Ethiopia, we should emphasize more on a very strong primary health care, where you can pick up the diseases early. You can change the health culture of the patients or our nation early. Knowledge about diabetes, about hypertension, present early. Enter the health service. This you can detect the tumors early. You can send them to referral early. You make the life of the surgeons and the physician in tertiary hospital easy. Patient will get more survival years. So this is quite important. I think this is a quite important issues in our setup. Can you brief us about CBD cancer and pancreatic cancer surgical management in our country, Ethiopia, about the outcome of the patient and meaning the reality? I don't know the what's up in Ethiopia here, but I have a presentation, will be with the Surgical Society about our experience in Sudan, for example, with the pancreatic adenocarcinoma and the surgical treatment, the outcome of the WIPP procedure. And perhaps that time will be also attended by surgeons, and then we can compare or we can speak about like what's the difference between here and there, and how we can like cooperate in providing better service for all our nation. Thank you so much. Can you explain some about the interval cholecystectomy and the onset of symptoms more than 72 hours stands as an indication of interval cholecystectomy? It's a good question. Actually, this has something to say with the emergency cholecystectomy. Nowadays, people in some surgical schools, not in all schools, speaking about the emergency cholecystectomy is done within a 24 hours of the symptoms. Some surgeons pushed up to 48 hours, but I think the safest, you have to be, the safety of the patient should have to be in the top of the priority. So it's 24 hours of the symptoms, you can do emergency cholecystectomy. But more than that, then you treat the patient as the acute cholecystitis, and then you give him an elective cholecystectomy. In between, if the patients between the discharge of the acute cholecystitis treatment and of the surgery have another cholecystectomy, then this cholecystectomy will become an emergency cholecystectomy. Here is more I can say, justified to do an emergency cholecystectomy here. Okay, so this is when you speak about emergency and internal cholecystectomy. Can you differentiate hepatitis from obstruction? Definitely, you can differentiate. The only mimicking is what I said in the beginning, that the intrahepatic cholestasis can give you a features of obstructive jaundice in hepatitis patients. One effect of obstruction is the coagulation. Would you say the role of vitamin K when there is no derangement on the coagulation profile? There, that's what I said. There is different schools. Personally, I don't give vitamin K if there is no derangement of coagulation profile, but still the old schools give vitamin K as a prophylactic. But in for an undergraduate, we speak about like there is a coagulation effect of obstructive jaundice, and you have to mention vitamin K. And you can mention that some schools give and some schools don't give, and then it depends on the school that the surgeons is following. What else in the contraindications of Whipple procedure beside portal vein? Portal vein involvement is not a contraindication. Abdul Hamid Shamil. Okay. I spoke about that portal vein involvement was a contraindication in early on, but right now there is a portal vein resection, there is a portal vein graft, there is a portal vein replacement with the graft, with synthetic graft. So portal vein is no more a contraindication. Superior mesenteric artery involvement is a contraindication. And in the presentation of the outcome of Whipple surgery, I have some presentations about some talk about portal vein resection that we did in Sudan in our unit. What is your comments on routine PTBD in perihilar cholangiocarcinoma and specific indication? It's definitely is not, you cannot say a routine, but it is indicated if the patient is jaundice, definitely. And usually most of the patients with the perihilar cholangiocarcinoma have jaundice, so it's a PTBD is a must, because you cannot do a hepatectomy in a jaundice patient. This will increase the complication of the surgery, complication with the anesthesia, so you have to drain the patient. As I said, the drainage is by ERCP, but in the case of the perihilar cholangiocarcinoma, we go for PTBD because in most cases, the ERCP will fail. And if you try an ERCP in a patient with the cholangiocarcinoma, perihilar, you have to do two stents, one in the right and one in the left. And usually it's a teeny tumor closing. So it's better to drain above the upstreams. Whenever the patient is jaundiced, then you have to drain him. Thank you so much. Thank you for the blessing prayers for Ethiopia and Sudan. What's in your opinion on of the choledochotomy after CBD in resource limited? Actually, in a resource limited, we put a T-tube because it's here you weigh the things that's the safety of the patient. The safety of the patient always in surgery you put higher up. So the PTBD or the T-tube usually, like for example, our classical teaching, it put a T-tube. If during the procedure you can dilate the CBD and you pass, like the example, the tubes or the choledocoscope when you are doing laparoscopic CBD exploration up to the sphincter of body, then you can close it directly and put a drain, and then you stand, provided that you have a backup, for example, an ERCP service on hand. So when you choose which is which, you have to look for the accessory service that you have. For example, you are in a remote area and you have no ERCP and you have a patient with biliary stones, then it's safer for you and for the patient to put a T-tube. You cannot go for a primary closure at that place. But for example, if you are operating in Addis, Helvetia, other hospital, having a nearby 24-hour ERCP, you have a choledocoscope, you did your operation, yeah, I can close with a primary closure. If anything happen, any accident, then I have this ERCP. So it weighing things. Always the wisdom of the surgery is of weighing things. They know hard and fast rule. Thank you all. Thank you. It's give me a great pleasure to present you and answer the question. What's the advanced lab test rather than you have experience on your materials in obstructive jaundice? There is not much like advanced. The tumor the tumor markers, we can say that this is the advanced. Maybe there is some other markers like the infection markers, the serotonin, the cytokines, but there is not much like if you speak about tumor markers other than this, no much advanced lab tests than the liver enzymes, AST, ALT, the globulins, that's it. But there is no much, if you know some, I'm very pleased to know always, I am always speaking that medicine have no limits. There may be some new things that, new papers I didn't pass through, then you can remind me. So this is the end of the questions. So thank you all for listening. I hope that it was a fruitful presentation. All get benefits from the presentation. I'm available, and thank you in Blue Health Ethiopia, and thank you, Molly. Have a nice night.
Thank you so much, Doctor. On behalf of our participants in Blue Health Ethiopia, we would like to thank you. And also, Blue Health Ethiopia wishes your country, South Sudan and Ethiopia,
thank you,
to live in a prosperous and peaceful world. Yeah, thank you so much, Doctor.
Thank you. Have a good night. Thank you all.
Have a good night. All right.